Okay, thank you all for joining us today. A few more folks may come online in just a moment, but mindful of your calendars and ours, we wanted to get today's webinar underway. My name is Denny Brennan. I'm the Executive Director of the Massachusetts Health Data Consortium, and I am delighted to welcome Melanie Combs-Dyer and her colleagues from Mettle Solutions. In the spirit of full disclosure, MHDC and Mettle Solutions are proposers for a project involving real-time data exchange between patients, providers, and plans that AHQ is interested in. It's a pleasure of working together. The page you see in front of you is a tweet, or you want to reach out to us with questions. We are recording this event, and we are keeping a presentation. So if you would like a copy of the presentation after the event, or would like to see the event on video, we will have in about next. Perhaps the next page, Lynn. Just briefly about MHDC. Many of you know us, perhaps many of you don't. We have been in business for 44 years. We're the only organization of our kind in the country. We convene the healthcare community, whether it's payers, providers, patients, service providers, government agencies. We bring them all together. And the purpose for bringing them all together is there are a lot of things that need to be done in this industry that are done much better collectively than individually. Prior authorization is one, and I'm sure we'll have a robust conversation about that as we get further into today's discussion. In addition to our webinars, and in addition to the meetings that we hold for members for a variety of purposes and a variety of goals, we have a data governance collaborative where we are working with payer and provider organizations to achieve interoperability above and beyond the rules that were finalized last year, and even some of the rules that are in review now. We recently merged with NEHN, the New England Health Exchange Network, and with the addition of NEHN's trading platform between payers and providers for X12 or HIPAA transactions, we have a full set of community managed, community governed data services. Lastly, we provide analytics. We collect data from multiple states to enable hospitals and health systems evaluate market share, disease prevalence, patient demographics. And we are in conversations with the Lown Institute to incorporate the Lown Institute's measures of social equity and other less classic measures, but more relevant than ever as part of our product. As part of our offering. If you have questions during today's discussion, please don't hesitate to put them in the chat box. We are monitoring questions. We'll ask questions as you raise them. And with that, I will turn it over to Mel. Thank you, Melanie.
Thank you so much, Denny, and to the Massachusetts Health Data Consortium. I really appreciate you guys welcoming me here today. Can you hear me okay?
Yes,
we can.
And can you see my slide?
Yes.
Yes.
Great. We are building with fire. Those were the words spoken by Dr. Don Rucker, the head of ONC, back in November of 2017 when he came to visit Administrator Seema Verma. She was the administrator at the Centers for Medicare and Medicaid Services, CMS, and they were to have a conversation about interoperability. And Dr. Rucker was trying to communicate to Seema how important it was to ONC this new concept called FHIR, F-H-I-R, Fast Healthcare Interoperability Resources. Here were two of the most powerful regulators in all of the federal government, ONC that regulates electronic health record vendors, EHR vendors, and CMS that regulates providers and health plans. Here they were talking about FHIR and interoperability. Dr. Rucker was also there that day to ask Administrator Verma to participate in something called the Da Vinci Project. It was brand new at the time, and he thought that CMS should be a participant. And that's how I became CMS's first representative to the Da Vinci Steering Committee. Hello, my name is Melanie Combs-Dyer, and to understand my passion for FHIR and prior authorization and all things medical records, it's helpful to understand a little bit about my background. I'm a nurse by training. I graduated from the University of Maryland School of Nursing in 1985 and got my master's degree in health administration from Towson a couple of years later. I then worked as a registered nurse at Frederick Memorial Hospital for a few years. And then I got a job at a company called Delmarva Foundation for Medical Care. Delmarva was a, what we called at the time, a peer review organization, or a PRO. And they had a contract with then the Healthcare Financing Administration, which later changed names to CMS. And their jobs, the PROs, the peer review organizations in each of the states, there were 50 at the time, one for every state. Their job was to go into hospitals throughout the state and review medical records, looking for quality problems and utilization problems. And so I did that. I was a medical record reviewer. As a registered nurse a few years previously at Frederick Memorial Hospital, of course, I had written in medical records and interacted in medical records. Of course, back in the 80s, it was all paper-based. And at Delmarva, it also was paper-based medical records. I would either go into a hospital medical record department and fill out a form, a paper form requesting the medical records, or sometimes I would fill out a form, put it in the mail, and I would receive medical records at home in the mail. A few years later, I worked for a company called Birch and Davis Consulting Firm. And Birch and Davis had a contract with then HCFA, now called CMS, to conduct an industrial engineering study of PROs throughout the country. I literally took a stopwatch and a clipboard into peer review organizations up and down the East Coast, and I checked how long it takes a nurse to order medical records, how long it takes a nurse to review medical records, how long it takes a nurse to review a case to a physician, and how long it takes the physician to do the review. It was quite an interesting job, and I'm really glad that I had it. In 1989, I began working at the Healthcare Financing Administration, and that was the beginning of my federal career. I was a health insurance specialist, and I worked in the part of CMS, then the Healthcare Financing Administration, that ran the Medicare fee-for-service program. And I was to spend the next 30 years helping to run the Medicare fee-for-service program. I spent almost all of those 30 years in the part of Medicare fee-for-service that operates the function known as medical review. It changed names in the organization many times. In the end, it was called the Provider Compliance Group, but it was the area that oversaw the contractors known as MACs, or Medicare Administrative Contractors, that receive the claims from doctors and hospitals all over the country, and that send out requests for medical records, receive the medical records, and review those medical records, trying to decide which Medicare claims should be paid and which ones should not. It was in that role that I helped to write the instructions, first requiring every MAC to accept medical records through a new technology known as fax. And then a few years later, through web portals. And then a few years later, through a new standard that ONC had developed called Connect. At CMS, we called the Connect gateway the ESMD system, or the Electronic Submission of Medical Documentation system, which made it more electronic, both on the provider side and on CMS's end. Finally, when I left CMS, I got an opportunity to help work on a couple of CMS regulations right before I left. And I'll be talking about those CMS regulations in just a few minutes. Soon after I departed CMS in January of 2020, I began working for Mettle Solutions, where I am now as their Director of Innovations. Mettle has a contract with CMS to be their fire server, and you'll hear more about that in a moment. I'm thankful that I landed at Mettle Solutions because they are very committed to fire, and they're committed to helping improve prior authorization and really reduce the burden that providers oftentimes experience in the prior authorization process. Our agenda for today is to talk about the standards that are helping to promote standardization in prior authorization. We'll talk about the Fast Healthcare Interoperability Resources, or FHIR, and I'll give you some more details about the Da Vinci project, where I was on the steering committee for a couple of years. Then we'll open it up for questions about standards, and I'll turn it over to a colleague of mine to actually give you a demo of how some of these standards can be put into operation. We'll then move on to talking about some things that CMS is doing to promote standardization in prior authorization. I'll talk about the regulations, and I'll talk about that FHIR server that Medicare fee-for-service is standing up. They've just gotten approved by CMS to go live, and they're searching for providers that might want to sign up and actually submit prior authorization requests on FHIR to the Medicare fee-for-service program. So I'll tell you more about that. The federal government always has acronyms for everything, and the acronym that CMS has for that contract is the Support for Prior Authorization and Documentation Exchange. So it's the SPADE contract. We'll then stop for a few questions about those CMS actions, and then we'll go to the third part of the agenda, which is the public efforts that are helping to promote standardization in prior authorization. There, I'll turn it over to another one of my colleagues, Jillian Flowers, who's going to talk about a team called the Uniform Elements for Prior Authorization. That's been stood up by HL7, and Mettle Solutions is very involved in that, and it's open to the public. We would love to have any of you join, and we'll tell you what that team is doing and how you can join. And then I'll talk for a little bit about an effort to digitize the Medicare coverage determinations. That is the Medicare policies that we hope are going to help to drive this whole thing forward. And then we'll stop for some questions about that. If time permits, I may talk for just a moment about computer-assisted review of documentation that CMS calls CARD. And I'll mention the Codex project, which is another FHIR accelerator project that is open to the public and looking for participants. And then a couple of words on clinical decision support. And I'll talk briefly about the project that Denny mentioned a minute ago, where MHDC and Mettle Solutions are working together on a proposal. We want this to be very interactive, though. So as you guys get questions, please make sure that you put them into the chat box. You can either address them to everyone or you can address them to Jillian Flowers, and we'll be stopping periodically for questions along the way. So we're going to start on the section about standards for promoting standardization in prior authorization. And I'll be talking a little bit about FHIR, about the Da Vinci project, and then that demo. So what is a technical standard exactly? I've heard the word standard used for many years. I know that it's an established norm about a technical system, but it really didn't hit my radar screen fully until I heard about the history of the railroad tracks in the United States. When railroads first started, the tracks were owned by different railroad companies. And so some companies built their tracks 4 feet apart, and some built their tracks 5 feet apart. And they were not interoperable at all. When the train traveling on the 5-foot tracks got to the end and met up with the tracks that were 4 feet apart, the folks had to unload everything from one train and put it onto the next train and move it along. That actually sort of reminds me of what the medical record world is like in our healthcare system today. So moving towards interoperability in healthcare makes sense, just like the railroad system did years ago. They finally agreed on a standard width for the track, and then all the trains could be interoperable. Standards development organizations, or SDOs, are the organizations that help us get there. They help to define the standards and update them and keep them maintained. And they do it through a collaborative process involving the audience that's going to be using a standard. So for example, the American Nuclear Society is the standards development organization for uranium and radiation and all that stuff. And the Consumer Electronics Association is the SDO for audio and video and cable and so on and so forth, always making sure that they involve the audience that's going to be using the standards as they come out. Are we going to be using VHS or are we going to be using Betamax? In healthcare, there are three main SDOs. There's the X12 organization, there's NCPDP, and they deal mostly with pharmacy and drugs. We're not going to be talking much about them today. And then there's HL7. X12 has developed a number of standards that help with things like eligibility lookup. They call that the 270 and 271 transaction. With attachments, those are like unstructured medical records, PDF medical records. They call that the 275 transaction. And the prior authorization cover sheet, that's also known as the 278 transaction. And an important footnote here is that there is an old CMS regulation, it's been around for many years, that requires every payer to accept prior authorization requests in 278 format. You'll hear me talk about that in a few minutes, and it's important to understand that that old reg is still on the books. Even though CMS is proposing some new things going forward, this old reg is still here, and it's posed a few wrinkles for those of us who work in the technical prior authorization space, that these new standards are emerging, but the old ones have not yet gone away. HL7 is the standards development organization that came out with CCDA, which is another attachment standard for structured medical records. And the newest one is called FHIR, or Fast Healthcare Interoperability Resources. And that's the one we're going to be spending most of our time today talking about. The FHIR standard allows for discrete data elements for the medical record to be included in a transaction. Checking the chat box to see if there are any questions, and I don't think I see any, but Jillian or Denny could interrupt me if they think they see some.
We did have a question that came from Janice Karen. Doesn't HIPAA require that the 278 be used regardless? There's talk about people seeking exemptions from it. Can you talk a little bit about, why that still sticks around and what you think is going to be its future?
Yes, and it's important to know that this is a regulation for payers. It is not a regulation that providers must send 278s. Providers can still send faxes. They can still do web portal uploads. They can send through ESMD. They could send through the US Postal Service. Of course, we won't get it till next Christmas, but they could if they wanted to. The 278 regulation is a payer requirement. And yes, every payer today must accept a 278. That does not mean that they cannot also accept faxes and web portals transmissions, ESMD transmissions, FHIR transactions, but they must accept the 278. I have heard that there are people who have been talking about requesting waivers. Not sure if there are any that have requested a waiver. I'm not sure if CMS has approved any, but it wouldn't surprise me if people don't start asking for those waivers and CMS doesn't start approving those waivers. And in terms of, do I think that it's going to continue or go away in the future? I'm not sure. I will tell you that CMS tends to add additional requirements without removing old requirements. Particularly when it comes to allowing flexibility for providers to still submit through fax and web portal and various means. So I'm not sure if it's going to go away, but you will see in some future slides that I'll be talking about how challenging that particular regulation can be. So I'm hopeful that at some point in the future, once the industry can demonstrate that prior authorization on fire works well, maybe it will be possible for CMS to say that payers are not required to accept every prior authorization in 278 format. The process that is used by most standards development organizations involves gathering the business needs, forming work groups, and you'll see a number of links during this presentation to various FIRE work groups or Da Vinci work groups, and they're open to the public, and that's where anybody who's on this call that is interested may want to get involved. There is a formal balloting process and a piloting process. That's another place where we would love to hear from you. If you work at a provider organization, or you work at a payer organization, or you work for a health IT vendor and you're interested in piloting some of these new standards, please reach out either to Denny or to myself and let us know that you're interested in piloting. We would love to hear from you. And then the whole thing repeats again, gathering more business needs, trying to update the codes and maintain the standard. It just continues and continues and continues. I want to stop for a second and talk about the difference between structured and unstructured medical records. Unstructured medical records is what I have been working in for most of my life as a nurse, as a medical record reviewer, as a federal regulator overseeing reviewers in the Medicare fee-for-service program. Most of the medical records have come in unstructured format. They come in PDF, or they come in the mail, and they look like this. They're in English. Human beings can read them. They make perfect sense to human eyeballs and nurse reviewers, but they're not organized in a predefined manner. And that makes them almost impossible to be machine readable. Structured information or structured medical records is what you need to make something machine processable. And this is what it looks like. It's the same information. Here you can kind of see medication information. You can see all the codes and stuff that appear in this structured document, but it's definitely not very human readable in this particular format. So what is FIRE? Well, FIRE is an alternative to the unstructured document-centric approaches that we've used for all these years. And FIRE exposes the discrete data elements in an electronic health record. They fall into various categories like clinical information, which might include family history, diagnostic information like observations, specimen, imaging studies, and medication, like when was it dispensed, when was it administered, and so on. And HL7, the standards development organization that has created FIRE, forms work groups, public work groups that are open to anyone to join, that identify use cases and create implementation guides. A use case is something like prior authorization. What do you need to do? What is it that you're trying to accomplish? And an implementation guide is a recipe. How are you going to accomplish that? The prior authorization support IG, or the PAS implementation guide, the PAS implementation guide, some people call it, is like a recipe for how a provider would actually submit a prior authorization request on FIRE, how an IT vendor would build an application so that an EHR vendor could allow a provider to submit a prior authorization request on FIRE, or a payer could use that recipe to show how they're going to receive the prior authorization request. Again, FIRE stands for Fast Healthcare Interoperability Resources. Resources is the term that is used for these discrete data elements. Observation is a resource, administration is a resource, family history is a resource. Let me stop for a moment and see if there are any questions. Moving on.
I think we're good for now, Melanie. I think so far so good.
Good. The Da Vinci project is a fire accelerator, meaning it is a group of people, a community of payers and providers that get together to try to solve technical, clinical, and business problems. They really are trying to identify those interoperability challenges, again, between payers and providers. And they do that by identifying use cases, situations where payers and providers don't communicate very well today, and developing those implementation guides. And you can see highlighted several times on the screen here, payer and provider. That's the one thing you should try to remember about the Da Vinci project. You may have heard about other types of fire accelerators. There's one called the Karen Initiative or the Karen Project. That is trying to work on the fire standards between providers and beneficiaries, or providers and patients. But Da Vinci is all about payers and providers, and trying to help payers and providers communicate better using fire. On the slide, on the screen now, are some of the members of the Da Vinci project. And if you want to join Da Vinci as a member, as a voting member, you want to get onto the steering committee, or you want to get onto the operating committee, you have to join, and there is a fee for joining, but you don't have to be a member to participate in Da Vinci. Da Vinci holds a number of work groups that are open to the public, and we'll be talking about some of them momentarily. But anybody who is interested in becoming a member of Da Vinci, there's a link down here in the lower left-hand corner, and I'll ask Janice, I'm sorry, Jillian Flowers from Mettle Solutions, if she could copy and paste that link into the chat box, so that anybody who wants to actually sign up as a member with Da Vinci can do so. This is what Da Vinci calls its dashboard of use cases. And you can see that there are a number of use cases, some that have to do with quality improvement, some that have to do with member access or clinical data exchange, process improvement. But the ones that we're going to be focusing on today are the ones that have to do with coverage and burden reduction. These particular use cases are called Coverage Requirements Discovery, or CRD, and Documentation Templates and Rules, or DTR. And in its regulation, CMS puts these two together, and they refer to these two together as a Documentation Requirement Lookup Service, or a DRLS. You can see from the little knob here, the little indicator, that CRD and DTR are in the publishing section. These are the furthest along. They have been tested at a number of connectathons, and they are going live. Just below CRD and DTR is prior authorization support. Prior authorization support is also very well along, though not quite as far along as CRD and DTR. And this is what you're going to be seeing a demonstration of in just a few minutes by my colleague, Shrikant Puram. Please notice over here what this, this little rust-colored outline refers to. This means that it was included in the CMS proposed rules. So payer data exchange was mentioned in the CMS rules, and the CRD, DTR, and PAS were mentioned in the CMS rules. Again, we'll talk about that more in just a minute. But if you want to actually go and see this dashboard live and watch as it gets updated from time to time, you'll want to check out this link, and probably hang on to the link. I keep this link in one of my favorites folders, and I check back once a month just to see how the knobs are changing and how things are working out in terms of being included in CMS rules. Jillian can also put this link in the chat box so that you have it. I did want to point out one typo that's on this screen, and one thing that I have my eye on, and that's called patient cost transparency, although on this slide it's called price cost transparency. But I did check with the Da Vinci project management office just before this a presentation to confirm that price cost transparency is the wrong term. Patient cost transparency is the correct term. And you'll see a slide in a minute where I talk about what that's going to look like in the future. You can see from the knob here that this is one that is in the early stage. It has not yet been balloted. It has not yet been published. It's very early on. And in fact, the steering committee and operating committee have not yet opened up any public work groups for this one, but it's one that I have my eye on. And for any of you who are interested in a patient being able to discover at the time of service how much that CAT scan is going to cost or how much that colonoscopy is going to cost that their doctor is suggesting they get, you'll also want to pay attention to patient cost transparency work group and follow along as the Da Vinci project brings that one to fruition. I'll stop momentarily and see if there are any questions so far.
Regarding patient cost transparency, Melanie, we've had recently the Consolidated Appropriations Act passed, and it has in it requirements that health plans provide what they call either an expanded or extended EOB, or explanation of benefits, so that when a patient goes into a visit with a physician, the physician is notified that the patient is coming for a visit, and during the course of that visit, the patient's going to be looking at how much things are going to cost them as they go through, if I need a CT scan or if I need a different service. So this is putting a lot on providers too. Providers are going to increasingly need to help patients make not just good health decisions, but decisions that don't economically, imperil them. Could you talk a little bit about that?
Absolutely. It's my understanding that some of the initial legislative and regulatory work that has happened so far talks about requiring hospitals or health plans to make information available on their websites or make it available through an API in FHIR format, but it doesn't really deliver it anywhere yet. And that's what I think patient cost transparency will do, is allow the provider to hit a button in the EHR right at the time of service and say, I really think you ought to have a colonoscopy, and this is how much your health plan is going to say that you owe because you haven't met your deductible, or because you have met your deductible, or because it's this kind of colonoscopy versus that kind of a colonoscopy. It's really hard for patients to make sense of that if they are looking at that information by themselves. And so having that information be discoverable by the provider at the time of service allows that conversation. If the patient is going to have that sort of jaw-dropping, I can't believe how much this costs moment, better for them to have it in front of the physician so they can talk about alternatives, rather than have that conversation when they're standing at the pharmacy or they show up to get the CAT scan and they realize how much money they need to put out front. Or worse yet, they don't even know how much it's going to cost, and nobody tells them until they've had the procedure, they've had the test, they've had the whatever it is, and then they get the bill in the mail and find out how expensive it is. I recognize that this is going to be sort of a new world for both patients and providers, but I think it's going to be a really important one. And I think it's one that will actually help to improve healthcare, the whole healthcare experience as we know it today.
One other quick question, Melanie. You mentioned the status of some of these different items at the Connectathon. Can you tell everyone what a Connectathon is?
Yes, a Connectathon is a place where usually IT developers get together and they practice without real patient medical record information, exchanging fake information back and forth. For example, Shri, who you'll hear from in just a moment, has attended all of these Connectathons, I think, since the very beginning, creating practice coverage requirement discovery transactions, or practice DTR transactions, or practice PAS, prior authorization request transactions, and then sending them to somebody else in the room who's pretending like they're a payer who's receiving the fake prior authorization request, and then sending back to Shri what the fake prior authorization response is. And then Shri can say, oh, I got an error message. You didn't do that right. Try again. And they can practice sort of in the room around the table. I guess it happens virtually now. There is no room. There are no tables. But it's really a great practice session for the IT folks to work out the bugs. And you can see that each one of these standards gets better and better and better the more of these connectathons they go to. Thank you for that question, whoever asked it. Here is a depiction of how CRD works. Here on the left-hand side, you can see the provider interacting with their electronic health record. This will be perhaps during the patient visit. They decide that they want to order a CAT scan or a colonoscopy or something for their patient. And they want to ask, is there a prior authorization that's going to be required by this patient's health plan? Or does this patient's health plan have any specific documentation requirements in order for it to be covered? Maybe they don't have anything that's checked during prior authorization, but after the fact, maybe the health plan would be stopping the claim, checking the medical records and looking for particular documentation to decide whether or not to pay the claim or deny the claim. Well, what are those documentation requirements up front? Once the provider hits the button in their EHR that says, let's do some coverage requirements discovery here, the transaction goes out to the FHIR-based exchange, and it pings the appropriate payer. The transaction knows who the payer is because it's written down in the EHR. You can't get to see the doctor until you've handed over your health card and said, I am a United patient, or I am a Humana patient, or I am a Medicare fee-for-service patient. And so that gets embedded in this transaction that goes out, and it tells the FHIR transaction where to go, which payer's documentation requirement lookup service should I ping to find out. Yes, prior authorization is required, or no, prior authorization is not required, or yes, there are documentation requirements, or no, there are not documentation requirements. Very similar to that is the DTR, the documentation templates and rules transaction. Again, provider is interacting with their EHR, probably during a visit with the patient. They have received back that, yes, there are prior authorization requirements, or there are documentation requirements. And so the third step in the process would be for the provider to send a request. Hey, payer, please show me your templates or show me your rules. And the transaction would go out and ping the payer and then come back and say, here are the documentation rules. In order to be covered, a CAT scan must have documented these 5 things, or here are the things that you need to document in order to have your colonoscopy covered. Here's what it looks like all together. Again, provider interacting with their EHR. Is there a documentation requirement or a prior authorization requirement? Yes or no? Yes. Are there any templates or rules? Here are the templates and rules. And again, you'll see an example of what this looks like actually in a, I think it's a Cerner EHR that Shri's going to be showing you momentarily. The benefits of this documentation requirement lookup service, the CRD and the DTR combined, are that it takes the guesswork out of patient-specific coverage by sharing whether the prior authorization is required and whether coverage depends on certain things being included in the electronic health record. And more importantly, it exposes the information when the care team is most likely to need it. For example, during the years that I worked at CMS, we worked really hard to educate the provider community about the coverage rules. And we would, in the old days, send out flyers, literally in the mail once a month, reminding the providers what the rules are. Here's what you need to document in your medical records. I envision that someone maybe was taking those flyers and unfolding them and sticking them up with a thumbtack to a bulletin board somewhere, hoping that physicians would be reading it and noting what they had to include in the medical records. We also have open door forum phone calls reminding providers, hey, dial in and listen to what it is that you need to document if you're ordering a wheelchair for your patient, or here's what you need to include if you're going to order diabetic test strips for your patients. Whatever it is, here's what you need to document. Later came web information, web postings about what it is that the provider needs to document. Unfortunately, with all of those modes of communication, it's not hitting the doctor at the right time. It's hitting the doctor at precisely the wrong time. But the benefits of DRLS is that it would hit the provider's radar screen at exactly the right moment. Right when they're getting ready to order a CAT scan, here are the rules. Here's what has to be documented. And not just for any patient, for this patient, given the health insurance that they have. That's important so that options can be discussed and informed decisions can be made between the provider and the patient. We talked a moment ago about patient cost transparency, and this is not an official Da Vinci slide, but this is Melanie's view of what it could look like, maybe, perhaps, at the end of all that CRD and DTR, finding out what the rules are. I believe that there could be a button that would say, what is the patient's cost? And that same transaction could go out, ping the payer, and it would come back and it would factor in whatever the fee schedule is, wherever the patient is in their deductible, and say, this is what the patient would have to pay to have that done. Here is what the prior authorization support transaction would look like. This should be looking familiar to you guys now. It's very similar format in each one of these. But you'll notice something different now with the prior authorization requirement here with X12 and this conversion to 278. This really gets at the question that Janice asked at the beginning of the presentation about that old regulation that CMS still has on the books. This is a slide for what does prior authorization support look like with the CMS 278 requirement in place. The next slide I'm going to show you is what it would look like without the 278 requirement, perhaps for those providers that have a waiver, or maybe someday CMS eliminates the 278 requirement. But with the 278 requirement, there has to be this conversion process to move it from FHIR to X12 so that it can go out and hit the payer. Without the 278 requirement, it could just move in FHIR off to the payer. Okay, Jillian, get ready to put some links into the chat box. There are a number of links on this page, and I'm going to try to walk through each one so that you can decide which ones you guys want to participate in. Keep in mind that although the Da Vinci Project, to be a member in the Da Vinci Project, you have to pay, you do not have to pay to participate. And there are a number of ways that people can participate without paying. The easiest one is to join the Da Vinci listserv. That way you can get periodic updates about Da Vinci. Here is the link to be able to join the Da Vinci listserv. You could also join the monthly public community roundtable. You could block your calendars for the fourth Wednesday of every month from 4 to 5, 5:30 Eastern time. And after you've blocked your calendar, you can then go to this particular link to sign up to hear a webinar about what's happening in the community. I'm hoping that maybe at the next community roundtable, or perhaps the one after that, will come the announcement about patient cost transparency. I would guess that at those, we would also begin to hear about maybe updates on the CMS regulation. That would be one place to get some updates, at least as the CMS regs pertain to CRD, DTR, and PAS. You could also join the Da Vinci Burden Reduction Implementer Support Call. This would be more for those of you who are on the call today who are IT developers, or you work at organizations who are trying to actually implement these CRD, DTR, and PAS standards. You could block your calendars every week, not every month, every week on Wednesdays from 11 to 12 Eastern time. And you can get more details about the dial-in numbers at this link. Finally, there is the Da Vinci Burden Reduction Supplemental Examples Call. Again, this one focuses on CRD, DTR, and PAS. And you can block your calendar every week on Fridays from 3 to 4 to participate in that one. And again, Jillian can send you the link for how to get to the calendar to get the dial-in information for that one.
Melanie, it's Denny. Just to add a little color to what you've just shared about, those three components of the prior authorization process. There are a lot of vendors out there who are selling prior authorization solutions that do not comply with these requirements. And the problem with that, and it's an issue that MHDC is actively pushing to prevent, is that if everyone has a system for prior authorization, say every provider has a system that chooses to communicate with the health plan in a particular way, the health plan is going to be looking at multiple connections from multiple systems, none of which are standardized. And my caution to those of you who are evaluating prior authorization systems is that you look for conformance with these standards, because if the data don't arrive at the health plan the way they're supposed to arrive, they will be rejected. And if they come back to the provider in the format that the health plan is required by CMS regulation to send it back, and the provider doesn't have the system properly configured to accept that, the software that the provider has invested in is worthless. So this is a bit of a soapbox for us, but we really believe that the value that technology can bring to prior authorization is how organizations use the data to improve the experience of the patient.
Denny,
that's the value.
That's a great suggestion, and I'm going to piggyback on that. I will second the notion that payers should always be asking, or health plans should always be asking to those vendors who are hawking their prior authorization solutions, is it FHIR compliant? That's really important. I'll also add that providers have two questions that they need to ask. First, they need to ask, is it FHIR compliant? But secondly, they need to also ask, is it an all-payer solution? We have heard, and there's been quite a bit of discussion and debate on some of these calls that were just listed on the prior screen about whether there could be health plans that develop plan-specific solutions. So if Blue Cross Blue Shield of South Dakota, and I don't know this for a fact, I'm just picking on them, making up an example. If they were to develop a FHIR solution that only worked for their health plan, that isn't going to be as helpful as an app that the provider could put in that is FHIR compliant, that is an all-payer solution. So I would encourage any provider who is on the call today, or any of you that are passing this information along to providers, they need to ask two questions. Is it FHIR compliant, and is it an all-payer solution?
Thank you.
This next slide talks about ONC's role regarding prior authorization. I think it's really twofold. One is that ONC requires the EHRs to contain certain FHIR resources. We call this the US CDI, and there's a link to it here. Jillian can put it in the chat box. Anybody who is interested in getting down into the weeds and actually seeing the actual FHIR resources that ONC requires EHR vendors to have can go here. But you'll see a reference, or you'll hear a reference to this USCDI later when we're talking about the Uniform Elements Work Group and how it is comparing prior authorization requirements to the USCDI rules. It's important to know that ONC requires EHRs to comply with that. ONC also has produced fairly recently an important report that I would point any of you to who are interested in this subject, called The Intersection of Clinical and Administrative Data. Again, Jillian can put this link into the chat box. Okay, so let's stop for a moment and look at where we are on our agenda. We have finished talking about FHIR. We have finished talking about the Da Vinci Project. I'm now going to open it up to questions from anybody. Maybe I can hear some of your voices about what questions you guys have, or if you don't feel like speaking up, you can put your question into the chat box. And as soon as we get done with that, we'll then go into the demo of the prior authorization solution, and then we'll go on to CMS actions and public efforts. But let me open it up to questions from the audience. Feel free to take yourselves off mute and ask me a question.
Well, I'm going to ask you a question, Melanie, because what you've described is, a method of not only taking the data through FHIR and being able to treat every data element as an end in and of itself. FHIR, gives you the ability to pull specific data elements rather than an entire medical record or an entire visit summary. You can pull the things that you're looking for. And prior authorization and the steps that you go through in prior authorization in what you do with those standardized data, they point to a future where a healthcare provider who is very good at treating patients who have particular requirements can become better and better at having what's necessary for prior authorization available before the patient even appears in the exam room. The idea at its, that the Da Vinci folks have talked about is that fully formed, this would allow even myself as a patient before going into the doctor's office to know that should I need any of the following things, they have already been approved by my health plan. Can you talk a little bit about that sort of forward-looking view of prior authorization, that it's not like today where everyone has to be filled, in a form, it has to go to the payer, it has to go through a process of adjudication. Here, if you're good at managing your digital house, keeping your digital house in order as far as the elements in the electronic medical record, you can start moving through prior authorization processes, in advance of patients for whom these are likely services that they're going to require.
Yes.
Talk a little bit about that.
Yes, I believe that providers are going to get better and better at knowing what needs to be documented in the electronic health record. And I also think it's going to be getting easier and easier for providers to do that documentation. In just a second, I'm going to be turning it over to Shri to do a demo, and you'll hear him, and you may even see the button called pre-fill or see pre-fill data elements. Be on the lookout for that. That is a place where you can see that the computer system has figured out, after the CRD and DTR transactions have been done, what it is that the payer needs to see. And the transaction has already gone shopping in the medical record and pulled in the places where the provider has already documented those things, so that the provider only sees what the missing information is. For example, if there are 10 things that have to be documented and 8 of them are already in the medical record somewhere, the lab results or the patient's tried and failed with conservative therapy or whatever it is, that can be pre-filled and not even shown to the provider. and only show the provider the one or two things that they're missing, unless the provider wants to hit show me the pre-fill, and then it will actually show all 10 data elements with all the information that has already been filled in. I think that is going to revolutionize the way that prior authorization is done for providers. I also believe that the notion of a provider being able to fill out the missing pieces of information and then hit the submit button, submit my prior authorization request, and get an answer back in 15 seconds is, again, revolutionary. Now, that's not going to happen overnight. It's going to take a lot of changes on the payer side. The health plans are going to have to be able to, A, have a FHIR server so they can accept this prior authorization request on FHIR. And they're going to have to put in automated review decision-making. Again, that's a possible agenda item that we can talk more about if time permits. CMS calls that CARD, computer-assisted review of documentation. And if a payer puts in a CARD system, that's what would allow the prior authorization request to come back so quickly. I think I saw a hand go up. Denny, can you check for hands that are up?
That was Kathy Gardner. Kathy, are you able to unmute your microphone?
Yes. Yeah. Hi, Denny. Hi, Melanie. I have a question related. As we're thinking through the automation of prior authorization, are we considering other elements that occur as part of the process? So, for example, I'm thinking eligibility checks, product verifications, limited network confirmation, all of these things that are rolled into different payers' products that have to be validated as part of a medical necessity or prior authorization review?
Thank you for that question. I would say that at this point in time, those are separate checks. The CRD, DTR, and PAS, the coverage requirements discovery, documentation templates and rules, and prior authorization support, has been sort of lumped together or bundled together. And the eligibility check is done separately. And I believe that the checking about whether a particular provider is in network or out of network is also done in a separate kind of a transaction. But I believe that when these things are FHIR enabled, and I'm not positive that eligibility is, but I know for sure that the checking the network, that's called provider directory, that is becoming FHIR enabled, and that I believe that future evolutions of these prior authorization systems will be able to bring in, for example, if we could combine the limited network that you just talked about, which providers are in this patient's network, along with the patient cost transparency, then the provider, the ordering provider, knows what to document, has gotten the prior authorization, knows what it's going to cost the beneficiary, and sees which providers are in network or out of network, and maybe can even see different prices at different organizations. If you go here for your CAT scan, it'll cost you this much. If you go here for your CAT scan, it'll cost you this much. That, I think, will be really cool when we get there. I think we're still a ways away, but the future's looking bright. Kathy, thank you for that question.
Melanie, this is Janice. How are you today?
I'm good. How are you?
Good. I have a question going back to what you said about USCDI and how getting all of the data because USCDI is in the EHR. Do you feel that at this point in time, all of the stuff that folks are going to need for prior authorizations is captured by, well, it wouldn't really be USCDI. It would be the US core stand-in that's used in FHIR, but that is captured within that data set? Or do you feel that that there are still things that are needed for prior authorization that would not be part of that very specific data set?
My answer to that question is I don't know yet. And the reason that I don't know yet is that I have not completed my review of every data element by every payer required for prior authorization and compared that to the US core. Of course, I can't do that by myself. That is exactly what the Uniform Elements for Prior Authorization team is going to be doing. And when that team finishes their work, And of course, it'll never be finished. This is going to be an ongoing iterative process for many years to come. They will be identifying those missing data elements and putting in the request to the US CDI or US Core at ONC to get those things added. That's a really good question, Janice. Thank you. It only makes sense. I mean, if a payer is going to require that a provider document something in the EHR in order to get paid, in order to approve their prior authorization, the provider ought to have a way to document that in their EHR. It ought to be very simple for them. If it's required to be there, there ought to be a place to put it. Any other questions? All right, I think at this stage of the game, I'm going to turn it over to Srikanth Puram, who's going to give a demonstration of a Da Vinci compatible prior authorization solution. Shri, take it away.
Thanks, Melanie. Let me share my screen. It'll unshare yours. Okay. Can you all see my screen?
Yes, we can.
Okay, great. Okay, so basically what I want to show here is like a provider's view of invoking a prior authorization request. And as Melanie mentioned, like I want to show you how the CRD, DTR, and the PAS components of prior authorization work. And I'll just walk you through two examples. In one example, it's a happy scenario where we want the world to be, where where we submit a prior authorization request, it goes to the payer, and you get a response immediately back. And then I'll walk you through another scenario where I'll submit a prior authorization request, and then you get a response back, and I would show you how a payer would actually approve it. Okay. So what you see here is a Cerner EHR. Some of you might be familiar with it, or you might be using other EHRs which might be similar to this. So in the Cerner EHR, what we did was we created something called as a Smart on Fire app, which actually sits within the EHR, and it takes care of in this particular example, it takes care of the entire prior authorization process. So ideally, what the CRD recommends is within the provider's workflow itself, you would be doing the CRD part also. Somebody is ready to do a sign of the order. At that time, internally, it goes and checks whether prior authorization is needed or not. So that functionality is called as CDS hooks. And Cerner at the moment, as we speak, they are developing this, but they have not yet implemented that in production. So that's why I couldn't demonstrate something which is within their workflow, but we would show the workflow that starts from the ordering process to the prior authorization request. So what you see on the left-hand side, these are all the Cerner menu items. And one item that you see here is the PayX. So this is a Mettle Solutions, our company's app. So you can see that this, once I click on this one, it brings up the app, which is sitting within Cerner. So this one, the PayX app, apart from prior authorization, it does a lot more things. It does clinical quality measures. It does the care gaps from a payer's point of view. And also it takes care of any external requests from the payer and those kinds of things. So basically it is we designed it as a one-stop solution for the provider to payer exchange. But just in the interest of time, and also to keep it in the context, I would walk you through only the prior authorization workflow here. I just reload it once just to make sure all this. Okay. So I'd open the request for prior authorization, and then here you can see that it already pre-filled a few things. For example, it says which encounter is this prior authorization referring to, and also what is the coverage for this particular patient is. And also on top of it, you can also do the orders here. So what I'll do is since we have the encounter and coverage already selected, so these are from the patient's medical record. So I'll start with one example, which is the complementary and alternative medicine. And then I would do a Botox surgery, which is actually for Medicare fee for service. It is one of the items which requires prior authorization. So I'm selecting the chemo denervation of one extremity. So this is the service that we are trying to check with whether prior authorization or documentation is needed or not. So when I click on the submit, it goes to the payer's server and it comes back with a response saying that prior authorization is necessary for this. And then when I click on proceed, it again connects to the payer. Let me just click on proceed because it takes a little while and I can talk after that. So when I click on proceed, what happens is internally it goes to the payer and it gets the template that the payer has provided and also the rules to pre-fill that template. So that's what is happening here. So it went to the payer, it's checking what is needed, and then you can see that it came back with a questionnaire here as to what all are needed. As Mel was mentioning earlier, by default, it shows you only the questions that are not yet pre-filled. So I'll just show you the questions which are pre-filled also. So the information that you see here, which has been pre-filled, it is pulling that from the EHR or from the patient's medical record. And also, on top of it, you can also see that there are these other elements which are more related to these are more like the cover sheet that you submit along with your prior authorization, the basic details that are needed to fill in an X12 278 internally. So here what we are doing is I'll go back to the questionnaire and I'll just again, yeah. So you can see that it asks for the questions which are not yet filled. So I'm just filling these. Yeah. So these are the questions that are being asked. On top of it, you can also select the documents that are already there in the patient's record, and then you can hit on submit, and then it submits the prior authorization request. It's that simple. So basically, it's in addition to the data that we have, it also it also allows you to attach anything like here that I'll show you in the next example that I show. So this is basically a happy use case where I'm submitting the prior authorization request and I'm expecting the data to come back. So internally what is happening is we have a payer system. So internally it converts the FHIR requests into X12 278. And then in addition to the X12 278 that gets generated, it also attaches the entire FHIR document to the payer. And there are rules that are being run on the payer side. So this is actually a live system. So it took the rules that are needed and then it took the FHIR data against those. It evaluated our FHIR data against the rules, and then it sent back a decision that the prior authorization has been approved. And it also sends you the prior authorization reference number, so which you can directly use when you are submitting a claim after this prior authorization has been done. So this is kind of in an ideal case, today, not many systems are doing this, but if we do this properly, because we have taken this particular example and walked through each and every step, and we also created the rules for the decision making. And also, as Mel was mentioning, we created the rules on how to capture the data from the EHR. And once we do this properly, your prior authorization would mostly happen when the patient is in the physician's office. So this is as simple as that. And you might have seen that I haven't really, it automatically picked up the payer the payer from the patient's record. And like, I mean, since we are following the standardized approach, regardless of whether it's the Medicare fee-for-service or Humana or like whichever payer, whoever conforms to the Da Vinci standard, it's exactly the same interface. So one of the problem that you see with most of the payers today is like, I mean, everyone follows a different standard and each one have their own portal. And now like the provider has to remember, like, I mean, what is this portal, what is the username and password for this portal, what is the URL for another portal. And tomorrow, like, let's say the vendor for that portal, like, let's say somebody has changed, they have to remember that. So it adds an additional burden on the provider to do this, and usually they leave it to the administrative staff. But even for the administrative staff, it is a cumbersome thing. Whereas in this case, like, I mean, the physician themselves, when the patient is sitting next to them, they can take care of the prior authorization activity. Before I move on to the next example, any questions here?
I think we'd all like to see this be the answer to a lot of prior authorization requests, but it was impressive.
Yeah. Okay. Let me move on to another example, which is a little different. Like, I mean, it's almost the same, but I'll show you what the difference is. This one. Okay. I'll just order a PA request again. And selecting a different encounter, like, I mean, where the patient has a blepharoplasty, and then we are looking for so I'm looking for a blepharoplasty of the upper eyelid. Even for this, CMS requires prior authorization, so I'm just clicking on submit. It goes to my internal server, and then it comes back with a response. Actually, it goes to the payer server and comes back with a response that prior auth is needed, and it again follows the same route. Like, I mean, it's picking the new questionnaire. Like, I mean, you would see the questions would be different from what it was earlier, because here, like, I mean, you sent a different code and different service, so the questions would obviously be different. The rules to pre-fill those would be different. And okay, it came back with a different questionnaire. You can see that, like, when I click on show pre-filled, like, it's showing the other data that's not yet pre-filled. And then the marginal reflexes, like, I just select yes for everything just for the sake of it. Okay, so you see that, like, you can select the documents that are already available, or like, I mean, what you can do is, like, I mean, you can attach the documents. Since this is blepharoplasty, usually, like, I mean, they look for images of the eye or the picture, because like otherwise, like, there are a lot of misuse that happens in this particular case. So they would ask for the pictures of the injury or the eye that needs to be taken care of. So what I can do is I select the images. I already have 2 images for this particular thing. So I just select them, and then I submit the prior auth request here. Okay, similarly, like, I mean, you can see that the basic details have been filled in, which are needed for the cover sheet thing. And then when I click on submit here, internally it goes and builds the prior authorization support object, and it submits it to the payer. And you can see that, like, I mean, it is pending for review at the payer's end. Okay, now what we would do is, like, I'll go back to a payer's interface and then show you how this particular thing is processed from the payer side, because what I've shown earlier was the provider side of things, and now I want to show how things work on the payer side for things which are pending. So let me reload this. Like, you should be seeing 2 requests. One is the recently approved one, and Okay, so you can see that there is an affirmed one and there is a human review one because I have submitted two prior authorization requests. So now I click on the one under human review. You can see that this is under human review. You can see the questionnaire response. Like, I mean, this is what the provider has actually filled in. These are the this is the data that we have filled in as a part of our submission. And then, so it went through a process, like as Mel was mentioning, like we have created the rules that are needed, and the rules are evaluated against the data that is submitted by the patient. And then there are review suggestions that are provided by the yeah. So there are some review suggestions that are submitted by the payer, and then you can see that like the decision has been given as a no here. So, but like under the documents, you can see that there is this eyelid image that was sent out, like what I have actually submitted earlier. You can see that the image has been submitted. And then what I can do is I can always edit this and then go to the item, and I can approve the prior authorization. And when I do the approval of the prior authorization, it actually, yeah. So what happens here is like after I approve this prior authorization, this needs to be transmitted back to the provider. In some cases, what can happen is like, I mean, instead of approving, like you can like wait for another reviewer to review this case and then submit the, then approve the prior authorization. So whatever workflow is there on the payer side, that is immaterial to us because that's taken care by the payer. But what I want to show is like once the payer has seen the prior authorization request, and if they want to, instead of automatically approving, if they want to do a manual approval, this is how it happens. We do a transmit status, and then the status actually is sent back to the one second, I just need to check. I do a transmit status, and then I go back to the submission. I do a reload claim response. You can see that it has been affirmed, and you get the prior auth reference number. So this is a workflow which shows you what happens in today's world, where like you submit a prior authorization, and here I did it immediately, but usually what happens is like, I mean, this happens at a later time, and then the provider can come back to the screen and check for like, I mean, what is the status of the prior authorization. And then in the home screen also, like you have various buttons, and I mean, that's more to do with our product, but we have put in a lot of these things. But in essence, what happens here is like this gives you a mechanism of a provider submitting prior authorization requests to multiple payers, whoever follows the Da Vinci standard. This not only submits the prior authorization request, but also it allows folks to check whether prior authorization is needed or not, and what information is needed by the payer dynamically. So that's what I have. Back to you, Mel.
Thank you, Shri, for that excellent presentation. A question did come in that during the demonstration that I want to tackle. So don't go too far, Shri. Listen and make sure that I'm answering this correctly. The question was, didn't this provider example still require active clinician participation, and how do we avoid that? I believe that the answer to that really has to do with provider education. And like I talked about earlier, CMS has worked really hard to educate providers about what needs to be documented for what item or service, and I'm sure other payers have too. But better than those flyers that get pinned to the wall or those web postings that providers can go read at their convenience, I think the example that Shri just gave, sort of reminding the provider, exactly what it is that they are supposed to be documenting in the EHR at the time of service, is the best education possible. And in those situations where the provider has documented everything that they're supposed to document, when they hit that submit button, it'll come back and say, you don't need anything to, you've documented everything you need to document. Is this ready to go to the payer? And off it will go. And again, if the payer is fully automated on their side, an answer will come back, either a red light decision or a green light decision, or a yellow light decision within 15 seconds. So I'm hopeful that that is the solution to that problem. Any other discussion on that? Kathy, can you ask your question verbally?
Sure. Sure. Following that workflow, and I think the prior question was getting at my question as well. It looked like the provider had a lot of clicks to complete the questionnaire and hit submit. And I'm asking, will this type of design that you're demonstrating here allow the provider support staff to complete those clicks? Anything that adds clicks, to the provider's workload makes me nervous. It'll be a failure right out of the gate.
I believe that answering questions about the patient's clinical condition and documenting them in the medical record, for example, that conservative therapy has been tried and failed, that is information that needs to be completed by a clinician, not the front office staff or back office staff. I believe that there may be some of that, like the submit button could perhaps be programmed so that would be the staff, the non-clinical staff. But I believe that when it comes to entries in the medical records, that probably is going to be reserved for the clinicians. Shri, did I answer that one correctly?
Yes, Mel. So in an ideal world, right, like let's say the provider really documented, like for example, has the conservative therapy been done? So if that was already documented, right, then it would automatically be pre-filled. So if the medical record is properly documented, I mean, I don't want to use the word properly, but adequately documented, then the support staff can take care of it, because all they need to do is they need to invoke the template and everything will be pre-filled. They just need to hit the submit button. So if the documentation is adequately done, then I don't think a provider is necessary. But if it is not adequately done, then probably, because there are some questions which the support staff may not know and the clinician may have to actually answer the question.
Kathy, did that answer your question?
It did, but I'd ask everyone to, as you're developing the product, to think about oftentimes the documentation supporting a prior auth might be coming from more than one provider.
Yes.
I'm thinking orthopedics, you might have a prior physical therapy history, prior pain management history. And so it could rely on several different providers to, have I think you understand why I'm asking
an excellent question. Point. Yeah. Excellent point, Kathy.
I actually have, this is Janice again. I have a sort of a related question from the opposite end of that. One of both this process and some of the stuff we talked about earlier, like the cost transparency stuff, a lot of this revolves around allowing the clinician to do extra things during the appointment, discuss additional factors with the patient while the patient is in front of them, and that all takes time. And in today's environment, the appointments are getting shorter and shorter. And I'm concerned that if we start saying it is great and it's fantastic, and I think all of these things are fabulous, but I think that we should also be looking, I don't think that adding 6 extra things that have to happen during an actual appointment without changing the appointment structure that we have in place at places is necessarily going to solve all of the problems either. I was wondering if you had any thoughts on that.
I do. I believe that this is, at least the patient cost transparency, as I think it's going to unfold, will be voluntary for providers. And even if it was to be mandatory, I don't think it would be mandatory that the clinician has to have that conversation. It could be somebody else in the provider shop that would have the conversation. But if clinicians are happy waiting until the patient gets to the pharmacy counter and then realize how expensive their diabetic test strips are, and then having to rewrite the prescription, if that's the workflow that they like, they can certainly stick with it. But if they think that handling those kinds of questions and having that dialogue up front, face to face in front of the patient is a better way to go, they would have that option at some point in the future.
Well,
Again,
I
not there
meant more
today.
on the patient side though, right? Because you're taking the time away from what the patient might want to address with the doctor, because the doctor has 10 minutes or 15 minutes or 20 minutes. And if the doctor spends 10 or 15 of those minutes dealing with this stuff, the patient doesn't get any of their care addressed.
I hear you. And there may need to be some adjustments that are made there. I don't know exactly what it will look like, but that's a very good point that you raised, Janice. Thank you.
I think there's also the likelihood that the workflow within a physician practice or within a multi-physician clinic will change. For example, in advance of a scheduled slate of patients coming in for the day, there may be administrative staff who are assigned the responsibility of identifying those patients for whom there are gaps in the medical record, or there's an expectation that the patient is going to need further treatment and a prior authorization is likely to be required. I think this gets back to that sort of digital hygiene comment earlier, which is the better and better, and doctors don't have to do this. The physician, the clinician doesn't have to do this, but organizations have to devote resources to making sure the electronic medical record contains as much description that is necessary to address an array of prior authorization requirements, and that can come as you mentioned earlier, and may come from multiple providers. So I think there will be changes in the workflow so that the physician is not spending a lot of time in front of the screen entering data. But I also think the physician is going to be the individual who's going to be sitting with the patient and saying, at the end of the session or at some point during the session, that I think you should consider A, B, and C because they're equally effective, but they're less expensive. There's less out of pocket for you. And I think we can get prior authorization for this in advance if we decide to go this route. So I think there are ways in which the workflow of an encounter can change so that a physician or a clinician can, one, rely on staff to help make sure that the patient's medical record is complete, that there aren't a bunch of notes instead of discrete data elements, and that they are able to, in advance of having to request prior authorization, look at options that the patient requires and guide them down a path in advance of prior auth. And that may simplify things considerably. But I agree, we can't have a solution that requires 2/3 of an encounter being a physician entering additional, doing additional clicks. Much of this will I think, increasingly be done, the work will be done in advance of the encounter so that the physician or the clinician with the patient can have that conversation as part of the treatment discussion. So I agree, we have to pull as much of this tapping out of the encounter and make sure that the clinician, before they see the patient, has as much in the way of a complete record and a path to helping that patient improve their health by picking sort of using evidence-based discretion, picking the services that make the most sense, but also recognizing that at some point in time, Mrs. Jones might need to have a CT. So we're going to look at the CT. We're going to get prior authorization for the CT in advance. We may not sign off on it because the patient improves, but it's something we can do beforehand. And I think that will change the workflow. And I think it will change the role of the people who now, are sitting in a room dialing every health plan and getting on the phone and getting prior authorization for physician requests. So
I agree with you, Denny. I think you're exactly right.
I think that's what we hope will happen.
Yeah, Kathy, one other thing, you were mentioning about the multiple, information coming in from multiple providers. So that is another use case. Like, I mean, just in the interest of time, we couldn't demonstrate that, but that's a very typical use case, and we have that functionality within the UI that you saw. Probably at some time we can demonstrate that to you. Just in the interest of time, we couldn't go over that today.
Thank you, Shri. Thank you, Denny. Let's move on. Let's see if I can get my, I'm having trouble moving on. Let's see. There we go. The next part of the conversation is going to be around CMS actions that have been promoting standardization in prior authorization. We're going to talk about some CMS regulations, and we're going to talk about the CMS FHIR server for the Medicare fee-for-service program called SPADE, support for prior authorization and documentation exchange. CMS has come out with 2 interoperability rules recently. They came out with a notice of proposed rulemaking in March of 2019. I call that interoperability rule number 1. And that encouraged being the key verb here, all Medicare Advantage plans, all Medicaid plans, and all marketplace plans to develop a documentation requirement lookup service using the Da Vinci standards, CRD and DTR, and to populate that lookup service with their list of items and services that are subject to prior authorization, and to populate their documentation requirement lookup service with the documentation rules for 2 items of durable medical equipment, oxygen and CPAP. Interoperability rule number 2 came out in December of 2020. And this is one that is now on hold, on pause. When the new administration came in, they paused this particular proposed rule, and I'm sure many others. And I have not heard whether or not this one is going to move forward or not move forward. I'm hopeful that at least these important pieces of it do move forward. But CMS proposed to require all Medicaid and marketplace plans, not Medicare Advantage plans, to develop a DRLS system using the Da Vinci standards, populate it with their list of items and services for prior authorization, and populate it with their documentation rules for all of their items subject to prior authorization. I am hopeful that they will come back at some point in the future and actually require this of Medicare Advantage plans as well. They said that they would do that in the preamble of this NPRM. I don't know if that's going to happen, but just wanted to flag everybody and make you aware of it. The official name of this NPRM, in case you want to Google it, is Reducing Provider and Patient Burden by Improving the Prior Authorization Process, CMS-9123-P. So let's look at what SPADE looks like. SPADE, again, is the prior authorization FHIR server that is sitting at CMS for the Medicare fee-for-service program. Well, it looks just like the ones that we've been talking about for in general. It takes from a provider entering in their EHR in some sort of a smart app that might look like the one that Shri just demonstrated. They would push the prior authorization request with attached FHIR medical record data elements. It would go through the normal conversion process, and then it would arrive at CMS. Now, CMS does not yet have in place the computer-assisted review of documentation. Instead, they will hand it off to their MACs, their Medicare administrative contractors, who will come back with a prior authorization response, but almost certainly at the beginning, the response is going to be pending for further review. We are very hopeful at Mettle Solutions that the Medicare fee-for-service program is going to move forward with their CARD, computer-assisted review of documentation work, and we'll talk more about that at the end. Please know that CMS is recruiting for additional providers that would like to sign up for sending prior authorization requests to Medicare fee-for-service on FHIR. So if you are a provider that is FHIR enabled or FHIR is on your roadmap, in the near future, please reach out and let us know. We really would be very interested in having you on board to the prior authorization FHIR server at Medicare Fee-for-Service. Any questions about CMS actions, either the regulations or the SPADE FHIR server?
This is Janice, not a question, but just a comment for the folks on the webinar. That frozen rule that Melanie talked about from CMS also involves a bunch of other things, including provider access APIs where payers send data to providers. So it is definitely focused on prior authorization, but there's a lot more in it, and we're all very eager to see what happens with that.
Thank you, Janice. You're absolutely right.
Any sense of, is this 50-50? Is it 75-25 in favor that this is going to pass? I mean, everyone wants burden reduction. But, you know, the health plans, and I think rightfully said, the comment period was only 17 days long when this rule came out. So it got
over the holidays.
And it was over the holidays. So it got pushed back. But it seems to me that this, along with, you know, surprise billing and, you know, the whole notion of engaging patients more effectively in the cost of their care, would be dealt something of a setback if this didn't go through. But I'm just asking for tea leaves. I don't know if anybody knows anything more than you do, Melanie, but I hear rumors, and I don't know if they're real or not.
What kind of rumors are you hearing, Denny?
The rumor I'm hearing is that by the summer, the disposition of this final rule will be set. Now, what that means, does that mean it gets finalized in the summer, or they open the commenting period for the new rule, however they change it at that time? I don't know.
It would not surprise me if CMS were to, if the administration were to allow for a longer comment period, maybe run it through another NPRM period. Maybe they would try to extend it to Medicare Advantage, which the original rule did not. But I do not believe that CMS will back away from FHIR. I believe that there may be extended due dates. There may be a little bit more flexibility in terms of timing, but I do not believe, again, I'm speaking only for myself. I no longer work for CMS, but my reading of the tea leaves is it will move forward, just maybe not on the original schedule that it was intended to move forward on. Anybody else on the call have any other rumors you've been hearing? Anybody want to chime in on your thoughts? Nobody brave enough like Denny and me to stick their neck out there and make a guess.
Right.
Next, we're going to talk about a couple of public efforts to promote standardization in prior authorization. We'll hear about one effort from HL7. Mettle Solutions is very involved in this one. In fact, I'm the leader of it. And Jillian is going to talk about that. And then when Jillian is done, I'm going to come back and talk about a Mettle Solutions effort open to the public to try to move forward standardization in the prior authorization process. So let me turn it over now to Jillian.
Thank you so much, Melanie. All right, let me get my screen set up here. Okay, so a little history on the Uniform Elements for Prior Authorization team. The origins of this group go back to the spring 2020 FHIR Connect-a-thon. And that's where there was a discussion about whether or not we needed payers to actually come together, work together, and figure out more uniformity in the documentation requirements that providers need to submit for prior authorization requests. Once we decided that that was definitely something that needed to happen, the debate was on these two items. Should we expect payers to agree on every single element? And that was quickly turned into, no, we don't think that's likely to happen. And instead, we should focus on developing a common superset of all of these different data elements that would be required for the different payers for the different prior authorization requests. We identified that the benefits from this could be reducing the burden for providers because they would know exactly what they needed to submit for these requests, faster production of the DRLS repositories on the payer side, and faster prior authorization determinations, hopefully eliminating that back and forth between the providers and the payers of, you forgot to submit this, or we need additional documentation. So once the idea came together, Melanie took it and ran with it and put together a work group. You can see on my screen, and this list needs to be updated a bit, but just so you have an idea of the diversity of the group, we have lots of payers, providers, and other IT vendors and things like that participating in this group. We truly believe that the diversity of this group is what makes it most successful. So we are always looking for more interested parties. There is a lot of work to be done. So if you are interested in joining this team, we especially would like to get a larger diversity of payers. Please feel free to reach out to me and I'd be happy to send you the information for this group. And I'll talk just a little bit longer about what we're currently working on and the goals of the group. Okay, so we are officially formed as an HL7 work group, sponsored by the Financial Management Work Group. And then the co-sponsor of our group is the Payer and Provider Information Exchange Work Group. We've settled on 3 main outputs, though our group has taken several twists and turns along the way. Overall, we would like to publish an informative guide under the HL7 work group. And to do that, we need to first identify what's missing. So we are working to identify all of the missing USCDI data elements and submitting requests then to USC for those needed, ONC for those needed data elements. And then also identifying missing PAS data elements and submitting those requests to be added to the PAS implementation guide. Our current focus, as Melanie mentioned earlier in the presentation, we started looking at the different data elements that would be required for specific procedures. And it led us to this road of looking at denial reasons instead. There's currently a lack of specificity with current denial reasons. And that's creating a lot of problems for all of those involved. So providers are left to guess how to correct the request that was denied and resubmit it. Providers don't know how to improve that. They're not learning anything from why the request was denied. And then payers are not compliant with the new CMS rule. The new rule requires that payers inform providers of specifically why a prior authorization request was denied. So if the reason just says, missing documentation, for example, that's not going to help a provider figure out what documentation was missing so that they can improve that practice moving forward. So this is what the group is currently tackling. It is a huge endeavor. We're making great strides toward that, but I do feel we will be working on this for some time to come. And as I mentioned, could use all the help we could get to work on those missing elements. A couple helpful links. So the work group does meet every week on Tuesdays at 4 p.m. So I will put all of these links in the chat as soon as I'm finished speaking in just a moment. We do have a Confluence page where we house our working document that is publicly available. So you can look at that to see some of the great work that the group has already done. And then our formal charter, our scope statement is also housed on Confluence. So you can kind of see what we've been approved to do, what the goals of the group are, and all of that sort of information. So again, I'll put these links in the chat. If you have any questions or you're interested, if you feel like this presentation has been a call to action, we would love to have you in our group. So please feel free to reach out. With that, I will turn it back over to Melanie, who is going to talk about digitizing LCDs and NCDs.
Thank you so much, Jillian. Can you guys see my screen?
We can.
Okay, and let me jump to digitizing LCDs and NCDs. For those of you who don't know what LCD stands for or what NCD stands for, LCDs are local coverage determinations and NCDs are national coverage determination. Those are the rules in the Medicare fee-for-service program for what is covered and what is considered correctly coded. And the Mettle Solutions team has decided to build an open source public repository of those rules that are converted into digitized format. Medicare, CMS has a website that you can go to and you can search and read the English version, the written human readable version of those rules. But Mettle believes that it would be really important to convert them into digitized form, excuse me, so that payers, any payer that wants to go pick up those rules and build them into some sort of a computer assisted review of documentation on their end could do so. By building in those rules into their own payer systems, that is what's going to enable that 15-second response for a prior authorization request. There's no requirement that payers pick up and do this with the Medicare fee-for-service rules, but we recognize that oftentimes payers do use the Medicare fee-for-service rule. So when they do, we think they're going to find this very helpful. So far, Mettle has digitized 30 NCDs and 4 LCDs, and we continue to work and count. In addition to LCDs and NCDs, Mettle is envisioning digitizing some of the Choosing Wisely and other publicly available guidelines. To really make this successful, we need help, though. Excuse me, we need help from the public to verify these codified rules, validate them, extend them, and really put them through the test. Excuse me. Mettle is going to be reaching out to the community in the next few weeks with ways that people in the public can participate in our effort to digitize these LCDs and NCDs. So in summary, so far today, we have discussed the challenge of prior authorization, where we are today as a community, payers, providers, IT vendors, other interested parties in the prior authorization space. And we've talked about what's necessary to solve the problems, allowing providers to understand when a prior authorization is needed. That's the coverage requirements discovery standard. Letting providers collect the relevant information at the time of service so that they can include it in their prior authorization request. That's called DTR. Automating the actual submission of the prior auth request and the receipt of the prior auth decision. That's the PAS standard. Improving consistency among the payers in the what prior authorization documentation elements are required and what the denial reasons are. That's the uniform elements team. And the plans to codify the Medicare coverage rules. That's Mettle's open source for digitizing the NCDs and the LCDs. So let me stop there and see if there are questions. And then we will go on to a couple of extra items that we may have time to sneak in at the very end. But first, any questions on the uniform elements team or the digitizing LCDs and NCDs?
You have your work cut out for you.
Yes, indeed.
So is that currently, are you planning on doing that in like a working group type style, the way these other projects are going, or how? Do you have any sense yet?
My guess, Shri, are you still on the line?
Yes, Mel.
How do you envision the digitizing LCDs and NCDs team working? Are you thinking it'll be a team that meets like in a call once a week, once a month? What are you thinking that might look like?
It may not be a call because mostly it would be an open source. It would be kind of an open source effort that, it would be a continuous development that is happening and folks contributing, and we would be making periodic releases. So that's the plan, and the entire code would be available on GitHub. Folks who want, they can use it, and also we would be providing ways to take them and test it and those kinds of things. So we don't plan to have any calls at the moment, but if there is interest among the participants, like we can definitely consider having calls.
Thank you, Shri.
It seems to me like there would not that there would need to be some discussion about exactly how to digitize certain elements or how certain things need to be interpreted in a FHIR world or a world that is not the way that they were originally written. But that's just my thoughts, and I haven't worked on it, so I might be wrong.
Yeah, I mean it is, but like I mean, definitely one call wouldn't be like there could be lot of offshoot calls that could happen. So like I mean, it may not be like it's not a standard that is being developed. It's actually an implementation. So it might require like a lot more time than an hour or two a week. So like I mean, that's the reason like we want to do lot of work offline and like collaborate more in terms of like the GitHub issues or like I mean taking care of them through other means.
Hey, Shri, this is Dave Delano. Are you planning to use CQL at all for
Yes,
documenting those? Okay.
yes, it is completely based off SQL.
Okay, thank you.
Yeah.
Okay, we're going to move on to computer-assisted review of documentation. We've talked about this a couple of times. I've mentioned it. It's really basically a rules engine that applies the digitized rules, like Shri was just talking about, to structured medical records. It produces a recommendation of a red light, a yellow light, or a green light. Red lighted cases are those that the payer would want to deny or non-affirm using Medicare fee-for-service parlance, plus a review reason code. Why was it denied? Was there a signature missing? Did they fail to document that conservative treatment was tried and failed? Or what was the reason? So that's what would happen with a red light case. A yellow light would mean it needs to be stopped for human review, or perhaps that more documentation is needed. And then a green light would be that it is approved or affirmed. And again, you could see how if a card solution were in place at a payer, it would be possible to make a prior auth decision in 15 seconds, at least for the things that they had the card built for. A reviewer cockpit is also sometimes included by IT vendors who are developing these card solutions, so that the yellow lighted cases would actually have an interface for the review nurse to look at the medical records and actually make that decision. You saw an example of a reviewer cockpit a moment ago when Shri was looking at the blepharoplasty case, and the machine had yellow lighted the case and said you needed to look at the photographs of the patient's eyelids. And so the nurse reviewer was able to click on the picture, the photograph of the eyelids, and do a human review. So that kind of a cockpit is often part of a card system. CMS, Center for Program Integrity, recently released a sources sought notice called Advanced Technology in Medical Review. If you're interested in this world, I would encourage you to read that sources sought notice. The time period for submitting responses to that has closed, but it's still a good read. And so I would encourage you, if this is your thing, if you like learning about this computer-assisted review of documentation, consider following sort of where CMS is. By them putting out that sources sought notice saying that they are looking to move in this direction, it looks to me like this may be the way that the Medicare fee-for-service program is going to go. I believe that CMS will leave it up to every other payer, Medicare Advantage, Medicaid, et cetera, in terms of letting them voluntarily decide if and when they would like to adopt a computer-assisted review of documentation systems. But my sense is that the Medicare fee-for-service program is perhaps going to do more than just talk about it or think about it. My guess is they're going to move in that direction. Any questions on CARD before I move on? The next slide talks about Codex. Codex stands for Common Oncology Data Elements Extensions, and this is another HL7 FHIR accelerator. It was launched at the end of 2019, and keeping in mind that oncology oftentimes has very complex treatment regimens that require prior authorization, and that delays in treatment can be really, bad news for the patient. Codex has been very actively involved in trying to figure out a way to reduce a burden for prior authorization of oncology care. And the current use case, this one is fascinating to me, is trying to set up to do prior authorization for an entire care path, meaning, please, the patient has this particular type of cancer. Let us, do a CAT scan. Please approve us to do a CAT scan. And if the tumor is less than this size, please approve us to do this and this and this. But if the tumor is larger than X, let us do this and this and this, and letting the payer approve the entire care path. We think that's going to be fascinating and really helpful for the community. Codex is using the Da Vinci standards like PAS, and they're also using something called M-code, which is the minimum common oncology data elements. And last topic is clinical decision support. This is basically letting the provider see when they're in the EHR helpful information to help them know what to do to the patient or do with the patient. It's hopefully going to be evidence-based and presented at the appropriate time. And you heard Denny and me mention that Massachusetts Health Data Consortium and Mettle have worked together to propose a solution to AHRQ, the Agency for Healthcare Research and Quality, for disseminating evidence-based information. It was a particular case that AHRQ put out. They said they were looking for solutions for making evidence-based information about non-surgical treatments for urinary incontinence available more broadly. And so Mettle and Massachusetts worked together, and this is what we came up with. I know it looks like a very busy slide, but it basically shows the patient going to their primary care practitioner who works in their EHR, who is able to go out to a Mettle server and connect to an AHRQ repository of rules that might have, instead of coverage rules like the DRLS has at CMS, this would be a list of the CDS guidelines. Here's how you treat someone with incontinence. You do test 1, you do test 2, do treatment A or treatment B. If A and B fail, you do treatment C. And all of this information can come right back into the EHR, including being able to go to the specialist and some version of it being able to go to the patient's phone. So we are very excited about this, and we think that this is going to be a really interesting way forward. We're very hopeful that AHRQ approves our grant proposal, but even if they don't, we'll continue to talk about and ways that we can move forward on this kind of a clinical decision support. And that is the end of my presentation. I will turn it back over to Denny. Thank you all so much for inviting me today.
Well, Melanie, thank you, and thank you to Jillian and the team. We put up a poll for folks to fill in. Please take a moment to cast a vote. We have a fair number of people, so if you're online and you can share your vote with us, we would be very much appreciative of it. We will have this presentation both in video format as well as the presentation deck on our website within the next 48 to 72 hours. One good thing to consider as you're thinking about attending our events is that starting in 2022, MHDC is going to be devoting a substantial number of webinars to the general public because as a not-for-profit association, we want to provide a public good. But we also are going to be providing an increased amount of member-only content. So some of our webinars will be members only. Some of our webinars will be community-wide. And we encourage you to send us, if you're interested in membership in the consortium, an email at info@mahealthdata.org. But starting in 2022, we're going to have individual memberships as well as affiliate memberships, which allow individuals and organizations to access all of our presentations and content at very reasonable prices. And we use a sliding scale. So if you're a small organization, you pay less than a larger one. So We encourage you to call us up or shoot us an email and find out more about what we're going to be doing in 2022. We're having some great discussions this year in our Vantage Point interview series that is going to be made available to the general public this year, but not next year. We'll be meeting with Mickey Tripathi to talk about his new role at ONC as the national coordinator. We're going to be meeting with Alexandra Drain, who many of you may know and leads the Archangel Project, as well as, according to her own bio, is a part-time cashier at Walmart. And we're also going to be meeting with John Glasser, one of the preeminent CIOs, certainly in the greater New England region and nationally, as part of that series. So we encourage you to join us. We thank you for presenting today, Melanie and team from Mettle. This was a terrific presentation. The scores speak for themselves. And we thank you all for joining us. And with that, right at the top of the hour, we'll adjourn. Thank you all very much.
Thank you.